Fever prevention in patients with acute vascular brain injury. Now, this study was intrepid, randomized clinical trial. Fever is associated with worse outcomes in patients with stroke, ischemic, or hemorrhagic stroke. Guess what? This was a good study. This was a good study, and this was actually a manufacturer-sponsored trial. This was the device for cooling. So we've been taught is that having a fever in a patient with acute vascular brain injury can cause harm. Just think about it is you're going to have with fever is you're going to have increased metabolic activity in the brain, increased oxygen demands, increased blood demands. All these things are going on, and this is going to stress out an already stressed out system. So basically what the study is that they use devices to cool the patient, and guess what? There was no change or difference between that. Now, is this the be-all and end-all? I still think that people want to avoid fevers in patient with an acute vascular brain injury. You want to avoid fevers, keep the temperature under control. Of course, when you're having a fever, you need to make sure that there's not a source of sepsis. But this is surprising. The results were surprising to the study authors. They expected with cooling, keeping the body cooler and reducing fevers, is that they would have less chance for brain injury. This is one of those trials where it didn't go as planned. So the device that they used reduced the fever, but did not functionally improve outcomes. So the outcomes did not improve. So crazy. CVA pearls, let's get some tips. Tips for board points and to do well on the wards and in the ICU. Permissive hypertension for 24 to 48 hours. Avoid fevers, this is the normothermia. Even though the study didn't go as expected, still expected to avoid fevers, and you want to make sure there's no source of sepsis. Possible if they had an event that they could have aspirated and can have an aspiration event. All patients start on 81 milligrams of aspirin, no need for loading dose. Consider 162 milligrams if they had a stroke on 81 milligrams of aspirin, or consider clopidogrel, switching to clopidogrel. DAPT, aspirin, and clopidogrel for high-risk TEAs. This is going to be is the ABCD2 score 4 or greater, or mild and moderate strokes, NIH strokes less than 5 for 21 days. 21 days, and never consider DAPT again. Well, also consider DAPT for 21 days, all TIAs and non-disabling strokes if patient has severe coronary artery disease. So these are controversial, but it looks like the evidence is good enough to continue doing DAPTs for these 21 days. Continue discussion on CVA pearls. MRI does not need contrast. The CTA is quicker. You get slightly better sensitivity and specificity compared to an MRA, Very large strokes made to consider holding anticoagulation. In this, we're getting more data on this for up to 10 to 14 days for fears of hemorrhagic conversion. Clopidogrel resistance, if there's consideration for it, switch to ticagrelor. Remember, you don't want to use Plastigirel in this. Do not use Plastigirel because increased risk of bleeding. Continue discussion of CVA pearls. Post-stroke, 69% had cognitive decline, a third had depression. Mediterranean diet, always, look at this. Just think about this. If a medication did a 30% improvement in prevention, that drug would be a blockbuster. So look what the Mediterranean diet, stroke prevention was 35, secondary stroke prevention was 30%. If that was a drug and you put it in a bottle, you would be a billionaire. So think how important it is whenever you see a dietary question, I don't care what the diet is, right now, if you see one of the choices, a Mediterranean diet, that's going to be the correct answer. High intensity interval walking training for stroke patients. We're here to pump you up and get you going. Compare moderate intensity training. High intensity training led to greater gains in walking speed as well as reduced fatigue. Many stroke patients have substantial impairments in walking. Post-stroke physical therapy and lack of intensity and volume to max improvement. So the patients benefit for high intensity training, then moderate intensity training. Patients may benefit at any point. The reduction in fatigue from high intensity training are equal important outcome. So basically saying is using high intensity training improve that versus the moderate intensity training. So The goal is to get the patients moving as fast as possible, as soon as possible, and as intensely as possible as they possibly can. And I know that's hard, it's easy to say sitting here in front of a computer, but the reality is we need to get our patients moving in all causes, in all cases, in all things. Our bodies are designed to move. Remember, exercise is medicine. I know it sounds hokey, but the reality is exercise reduces malignancy and it helps improvement after we have disease, especially after we're having a stroke. Moyamoya disease, we touched on this briefly before. This is a chronic occlusive cerebrovascular disease involving the bilateral stenosis or occlusions of the internal carotid arteries and their proximal branches. This is mainly can be noted in Asian populations. Females rarely progress to cerebrovascular disease. It can cause strokes or TAs followed by muscular weakness, paralysis, or seizures. The puff of smoke, that's a moyamoya. The puff of smoke is a Japanese term, noted on imaging, describes the look of the tangle of tiny vessels formed to compensate for the blockage. Constrictions in the middle carotid artery, collateral are small, weak, and prone to bleeding. Patient can survive on the collateral circulation from the basilar artery. Treatment, antiplatelet agents, and surgery that can help restore blood flow. All right, so let's go back. This patient was the 67-year-old male noted for sudden right-sided upper extremity and lower extremity weakness and difficulty speaking. The patient gets TPA, TNK, and then is noted for this. Why are we showing this? Well, this case actually happened. What happens, I want you to know that there's a risk for angioedema with these medications, less than 1%. What would your treatment be? In this case, this patient had to be intubated to protect their airway. This patient received epinephrine, steroids, and H2 blockers. Just to make sure you're aware of this risk, yes, they have increased risk of bleeding when you're doing you can see this right here. Let's go back to that real quick. You can show this increased risk of bleeding on here. You can see this right here during the intubation. Patient did well. 23-year-old male has difficulty stepping through the door. So they're walking, and they do this weird kind of stopping or steppage gait when they go through the door. It becomes hard for them to walk through the door. There's no obstacle in the door is open, and they used to be able to walk through that door fine. This is a house they lived in for 30 years, and they have trouble walking through the door. What is this disease? Parkinson's. Loss of dopaminergic producing neurons in the substantia nigra along the aggregation of the alpha synucleotide protein and formation of Lewy body inclusions. Clinical presentation currently is made, now they're starting to become blood tests. Right now the diagnosis is made clinically. In a short period of time there will be a blood test that can help confirm this. So you have tremor, it's asymmetric, more pronounced with resting. Handwriting is small and irregular. Essential tremor, remember the handwriting is large and tremulous. So how can you tell the difference between a resting tremor and essential tremor, essential or moving tremor? You have the patient point to their nose and point to your finger, and if it's like this is an essential tremor. If there's no tremor during that and there's only a tremor during resting, that would be consistent with a Parkinsonian tremor. Bradykinesia, small, slow movements, abnormal finger and toe tapping, decreased arm swing, slow gait, dragging of feet, shuffling gait, falls, fixed, expressionless face. You can have rigidity, gait freezing, postural instability, increased risk of falls and dementia. They'll have normal strength, normal deep tendon reflexes, and normal sensory exam. So the clinical presentation are these. Diagnosis made clinically only. There are some blood tests that are becoming available and will be FDA approved. We'll discuss those as they become available. Parkinson's syndrome also presents with autonomic dysfunction. You can have REM sleep disturbances, mood issues, and cognitive impairment. Symptoms can precede motor symptoms by years. So they also are going to have hyponesia, which is a decreased sense of smell. On here is on the testing. You pull the pullback test is when you stand behind the patient, you pull the shoulders, and the patient becomes unbalanced. Normal patients will take 1 or 2 steps backwards to regain balance. Parkinson's, more steps to regain balance, or they may fall. So basically, as you stand behind the patient, you pull them, you need to make sure there's a safety mechanism. You don't want them to fall and bust their hip, and you've caused this. So you pull back on them. Normal patients take 1 or 2, 3 steps to get stabilized. Parkinson's are going to take more, or they may fall. 4 cardinal signs of Parkinson's disease. We discussed resting tremor. Now remember, if it moves, it's a moving tremor, it's not going to be Parkinsonian. It's a unilateral onset, remains asymmetric, worsening with outstretched hand or during ambulation. Outstretched hand, you see this. And if you want to know, it's 4 to 6 hertz, if that's important to you, that decreases with voluntary movement. 4 to 6 hertz of tremor that decreases with voluntary movement. Bradykinesia, gradual decrease in amplitude of repetitive movements. Also see micrographia, which is small writing. Facial masking, reduction in arm swing, walking like this. Fine and loss of fine and gross motor movement difficulties. Cogwheel rigidity is that when you go, you ask them to flex and you'll feel this, like a cogwheel is going to be this kind of like a gear. We'll call it like a gear. You're having trouble moving in this kind of, instead of a fluid movement, it's going to be like this, segmented moving forward. You have gait and postural impairment. They have hesitation at onset of gait and turns, severe loss of postural reflexes. Parkinson's disease is made on history and clinical examination, require the presence of bradykinesia, and at least one of the other resting tremor, cogwheel rigidity, and gait postural impairment. Noted for absence of red flags for atypical forms of Parkinsonism. Brain MRI is recommended to rule out vascular lesions and hydrocephalus. SPECT with loparium 123, it's a dopamine ligand, shows reduced ligand uptake in the basal ganglia as a result of the degeneration of the dopamine terminals. These are starting to have these tests. They're going to become available for assistance in diagnosis. A lot of times you're going to get diagnosed by a specialty in neurology. If it's available in your area, there's movement specialists. They're going to specialize in Parkinson's disease, because it becomes important, because not only is the getting the diagnosis, there will be a blood test to make it easier for other laymen who are not these movement specialists, but to make sure we have the right diagnosis and right treatment pattern. There's a lot of nuances. There's an art to treatment in Parkinson's disease. Secondary causes can be drugs, phenolphthaleins, serpentine, metoclopramide, antipsychotics, and lithium can cause similar presentations. Toxins, carbon monoxide poisoning. I don't know how far you're going to get with that, but yes, MPTP and mercury poisoning, head trauma, Wilson's disease can have similar presentation. Treatment of Parkinson's disease, first line is dopaminergic agents. Levodopa, dopamine precursor, plus carbidopa. It's a peripheral dopamine decarbonase inhibitor. This stops the levodopa from being broken down peripherally because you need it to work centrally. Levodopa plus carbidopa plus intercarotid. This is a CMOT inhibitor. This is a catecholaminergic methyltransferase inhibitor. Where have you seen this medication a lot? This is what the tech bros are using. They feel that this is giving them an edge. So you'll see some of the tech bros are using it. Maybe you're a tech bro, and this is helping you or helping you with your studying. Dopamine agonist, bromocriptine, there you go. We talked about bromocriptine before. Rarely can cause retroperitoneal, pleural, or pericardial fibrosis. It has GI side effects. Pramipexole, robenol. Secondary line alternatives, MAO inhibitor, sertraline, MAOB inhibitor, sertraline, anticholinergic benzotropine, given with psychiatric medications to prevent tardive dyskinesia. This is odd movements that can be a forever thing. There is medications for that now. Better in younger people that can tolerate the side effects, which is urine retention and constipation. Remember, increased risk for urine retention as we get older. MNDA antagonist, amantadine. Remember, amantadine was originally used for influenza. It's not used as much anymore, but is used for treatment of movement disorders. Better in older people greater than 65 to avoid anticholinergics. Continued discussion of treatment of Parkinson's disease. Surgical treatment, you can have a deep brain stimulator with implanted electrodes. When you have complications to the dopamine therapy, wearing on-off wearing off phenomenon, meaning you take these medications, they're going to have a variable half-life in certain individuals, and you start becoming resistant to it, so you have to change when you're doing this. So this becomes where it's an art. And literally you can look at patients, and if they have a great movement specialist, they're going to say, hey, you're going to take these ones at these time, these are your long-acting at this time, your short-acting at this time. So basically they're working through, and it's an N of 1. They're sitting inside the provider's office, and they go, okay, when do you start getting your symptoms again? When did you take your pill? When do we need to give you a short-acting or long-acting or change your dosing? And it becomes where it has to be adjusted frequently because the body adjusts these medications. Increasing dose and frequency of levodopa, added dopamine antagonist plus a CMMOT inhibitor can have nausea and vomiting from the carbidopa dose. So these are the side effects you have to mitigate. Dyskinesia is chloroform, dystonic movements. Chloroform is a weird dancing movements. Remember, no medication slows the progression, only helps with some symptoms. Rigorous daily exercise, it helps with gait improvement. Early symptoms may not need treatment. So this is changes that before wanted to kind of hold on taking these medications. The newer literature says you can start these earlier. Addition of dopamine antagonist plus or minus amantadine. Mild symptoms, MAOB inhibitors, so you can be like the tech bros. Dopamine antagonists, those are the most effective drugs of choice for motor deficiencies. Carbidopa plus levodopa, remember carbidopa is the decarbatase inhibitor, are used together, allows the blocking of peripheral adverse effects. Psychosis, this is the adverse effects, okay? I want you to remember, we want to avoid haloperidol and risperidol. 40% of patients who have Parkinson's get psychosis from the medications. Quetiapine has the smallest amount of adverse effects. You can't just stop their medication. So if they have adverse effects, you just don't stop them. These are why it's important when these patients, that's why you have to know this even though you're not a neurologist. When they get inpatient, you have to maintain these medications. If you stop the drugs, they freeze. They can have rhabdomyolysis. So you can't just stop these drugs. Monitor infections or other causes. Discontinue anticholinergic medications, amantadine or dopamine agonists. But you have to watch this worsening on-off phenomenon, meaning they work and then they stop working and they need to be adjusted, but you can't just stop these medications. Adverse effects may require reducing the doses of levodopa as well. Pimavanserin is an antipsychotic for Parkinson's. The mechanism is a 5-HT antagonism. It does not inhibit dopamine. It increases QT prolongation. When required, quetiapine is the antipsychotic of choice. Now here's this right here. This is the study where it says early versus delayed use of levodopa. Before it was thought to hold levodopa because you would basically use this medication and basically the effects, it would wear off and this medication wouldn't be good for these patients as they get older. There was kind of a concern. And this is the LEAP study, was levodopa in early Parkinson's disease. Basically, they wanted to wait till the symptoms get worse before start this medication. And it was reported, dyskinesia was reported by, in the early start group and patients in the delayed start group, a non-significant differences wearing on-off of levodopa was the same between the groups and did not differ between the groups. So starting early to get the patient's symptoms improving as soon as possible. So this has been a change in our theory. This is a recent study that gives change in the way we're giving these medications. Here's another thing that can be used as a deep brain stimulator, delivers stimulation to the targeted brain regions with module activity within these regions. Let's talk about the Parkinson Plus syndrome. 10% of patients who with clinical diagnosis of Parkinson's but have faster progression and absence of levodopa response. These are why these are important because they get different treatment. Progressive supranuclear palsy. This is a vertical impairment. So in the clinical vignette, or when they're in your wards or in your clinics, they say, I have trouble walking downstairs. Why? Because they can't see, because it's hard for them to look down. Think of it, progressive supranuclear palsy, they have trouble looking down. They have frequent falls, postures, they have instability, They have hyperextension of the head and neck, cognitive impairment and dementia. Can also have facial dystonias, which is surprise difference. They're walking around looking like the Joker all the time. They're like this. They're like this. How about multiple system atrophy? This is another Parkinson's with cerebral ataxia and early postural instability and falls. Combination of Parkinson with dysautonomia, which can be a shy-Jagger syndrome. So combination of Parkinson's with dysautonomia. Then we have cortical basilar degeneration is asymmetric Parkinsonism associated with dystonia, myoclonus, and cortical sensory defects and cognitive defects.